owners of this. We pay tribute to their physical and spiritual connection to land, to waters and to community, enduring now as it has been throughout time. And we pay respect to Aboriginal and Torres Strait Islander people, to their culture and to elders past, present and emerging, and particularly welcome any Aboriginal or Torres Strait Islander people who are joining us on our meeting this evening. As I said earlier, this evening we'll be talking about pharmacological and non-pharmacological interventions to slow CKD progression. As in all the ECHO sessions, it would be terrific if people are in a space where it's comfortable to pop your camera on. It's much easier for our lovely presenters to talk to faces than to names on black backgrounds. So we'd be thrilled to have those. As we've done in the past, the session will be recorded for the purpose of popping the didactic presentation by the panel up onto the SAPMEA website afterwards, so you can review the content, but Q&A at the end won't be recorded. So we'd really ask if you don't mind typing questions that pop into your mind while Ali, Anthony and Han present into the chat box, and we'll come to you straight away at the end. Similarly, it would be really nice to know who's here tonight. So we'd be thrilled if you could pop into the chat box who you are, where you are, and what you do, so we know a little bit about the people joining in and listening to this meeting. I might move on to getting our panel to introduce themselves. So we'll start with Ali Whiteman. Ali, where are you tonight? What do you do? What brings you to this CKD ECHO?
Hi, everybody. My name's Ali. I'm a nephrologist at the Royal Adelaide Hospital, and I look after the Broken Hill dialysis unit. I am at the moment in Unley at my house, and I'm here tonight because I love kidneys and I want them to, but as much as I love kidneys, I don't love dialysis. I want to keep people off dialysis, and so I'm very passionate about anything and everything we can do to help slow CKD.
Super. Thanks, Ali. And Anthony, good evening. Thanks for joining in.
G'day, everyone. My name's Anthony. I'm renal dietitian, primarily based at Royal Adelaide Hospital, but part of the whole Carlin renal team. I'm involved with every aspect of the journey of people with chronic kidney disease, from early stages right through to dialysis, transplant. And a bit like Ali, we'd much rather people not be on dialysis, so we've got lots of positive things we can contribute. So looking forward to having a chat.
Super. Thank you so much, Anthony. And Han, hi.
Hello, everyone. My name is Han. I'm one of the renal pharmacists at the Royal Adelaide Hospital. So I work along with Ali, other nephrologists at the Royal Adelaide, and Anthony's, and I'm looking after a whole range of different patients cohorts, including CKD, dialysis and transplant. So thank you for having me.
Thank you all so much for joining in. I'll hand over to you guys now to start your presentation. Thank you very much.
Okay. Very good. So, thank you. So, as we said a couple of times, talking today about pharmacological and non-pharmacological interventions to slow chronic kidney disease or CKD progression. So just quickly to start off with, when I'm talking about chronic kidney disease, what am I talking about? I'm talking about either GFR, people with GFRs that are less than 60 mils per minute, or people with other indicators of chronic kidney disease, be that proteinuria, be that hematuria, be that structural abnormalities, so thinking polycystic kidney disease, or basically any or all that indicate that there is disease in the kidney. So I think one of the most important points I want to make today is that chronic kidney disease more and more is actually a treatable condition. We can't yet heal kidneys or improve GFRs substantially most of the time, but there's a lot we can do that can slow progression of chronic kidney disease. And I think the bottom statistic that's on this slide here, that that some of the newer agents in combination with the older agents and in combination with non-pharmacological management can actually delay progression of kidney disease by 15 years or more. And that can be enough to keep somebody off dialysis for their life, which is, I think, a really important goal. So when we think about our targets, when we are managing chronic kidney disease, when we're trying to slow progression, as well as sort of addressing the blood tests, if you like, looking at the creatinine, the GFR, we also want to be reducing the amount of albuminuria, and we want to be controlling blood pressure. Now, the other things that people don't necessarily always think of, or patients certainly don't always think of when we talk about looking after kidneys, is that the biggest mortality risk for people with chronic kidney disease is actually cardiovascular disease, and it substantially contributes to people's cardiovascular risk. So part of managing progression of chronic kidney disease, mitigating progression of chronic kidney disease, is really aggressively treating their other risk factors for cardiovascular disease. And the other aspect of it is also trying to avoid having acute kidney injuries, because these are going to move people, even if they recover from the acute kidney injury, are going to move people along that CKD path. So I'm going to start off first with the non-pharmacological management strategies and then move on to talking about the medication side of things in the second part of the talk. But actually for this part, I would like to, I'm very fortunate to be joined by two renal experts today, Anthony, our renal dietitian, and Han, our renal pharmacist. And rather than butcher this myself, I'm going to hand over to Anthony to have a quick discussion about some of the dietary things, because this is the thing I get asked all the time in clinic.
Thanks, Ali. I think the recommendations here, you can obviously read them quicker than I can talk about them, but there's some important things, because this is very much about the earlier stages of kidney disease and the things that we can do to sort of slow progression. So in many ways, that idea of sort of renal nutrition, if you like, isn't really what we're talking about here. We're talking very much about good, sensible, healthy eating in reality, which means trying to avoid excess salt, trying to include plenty of fruits and vegetables, whole grains, legumes, etc. The sort of normal things that we would do to help someone with their blood pressure, with their diabetes, with their weight, look after their gut and the general healthy things to do. There is some, I guess, important differences here from previous iterations of this booklet. And I think these are much more sensible, I guess, directions, really. In terms of the fluid side of things, it's nice that it's not being quite so prescriptive in terms of fluid. We really want people to drink well in sort of healthy amounts, drink water primarily, and avoid sugary drinks. But, that's pretty much healthy advice for everybody, not just someone with chronic kidney disease. There is this idea around the ultra-processed foods that's in the bottom section there. And really, this is the foods that I think we all know are not particularly healthy foods, whether they're particularly high sugar, high salt, high fat, but generally nutrient poor. So these do feature in a healthy eating pattern, but in a small amount, and should be really considered that way. So I think that to summarize this in, I guess, a few words is, for the earlier stages of kidney disease, we really are just talking about good, sensible, healthy eating. We are not talking about potassium restrictions, phosphate restrictions, protein restrictions, those sorts of things. So we really want to avoid sort of even giving any hint of that sort of advice in the very early stages of kidney disease, because people tend to get quite carried away and end up doing things that they don't really need to do to their own detriment. But that's enough from me, Ali.
Thank you very much, Anthony. Oops, so as well as diet, I often get asked in clinic by patients about whether their alcohol intake has affected their kidneys and whether they need to change that. And I think the interesting thing about this is that we don't have specific recommendations because we don't have good evidence that there's particular harm from alcohol to the kidneys. What we do have good evidence of course, is that there is plenty of harm from alcohol, particularly excessive alcohol, in a whole range of other areas. So the recommendations that are in the KHA handbook are that you should adhere to the normal healthy levels of alcohol consumption as recommended for anybody. There's no specific recommendations for people with CKD. Now, what we do have evidence does help in CKD and in slowing progression is about being physically active, and particularly not just in terms of aerobic exercise, but also muscle strengthening exercise. It's particularly, it's as much about trying to keep people in good physical condition in the early stages of their CKD as much as possible. So again, this isn't different, and it does reflect a bit what Anthony was saying about it's the usual recommendations we would give to people in terms of healthy habits, but there is some evidence that will help with their CKD as well. Kind of connected into all of this, into the ultra-processed foods, into the alcohol, into the being physically active is also about people's weight management, because we know that that being overweight and obese does increase your risk of having chronic kidney disease, and it can have an impact on the level of protein in your urine as well, which in turn increases your risk of having progression of CKD. So particularly for people who are very overweight, strategies, both pharmacological and non-pharmacological, to address their weight can also be powerful in terms of looking after their kidneys. Okay, so then coming to the second part of the talk today, which is about medications that we've got to slow progression of chronic kidney disease. We've got some old ones, we've got some new ones, and I'm going to be talking through them in the next couple of slides. Ideally, in a perfect world, the recommendation is that you have somebody on all of these. We are going to talk a little bit about some of the practical difficulties in achieving this, and sort of I'll say where I tend to put my efforts and energy. But the 5 pillars, if you like, that we're going for are ACE inhibitors or ARBs, cholesterol lowering medication, ideally statins. The SGLT2 inhibitors are obviously a relatively new player in the mix, but increasingly good evidence that they slow progression of CKD. Even newer on the block is the non-steroidal MRAs, so like Firinone, and also very topically the GLP-1 receptor agonists as well. As well as sort of contributing to things like weight management, there is now growing evidence that they also are independently beneficial to your kidneys. So, starting with management of high blood pressure. So the target that we have set in the Australian context in the kidney handbook is we would like people's blood pressure to be less than 130 on 80. If you look in the American guidelines, you'll actually see they're more aggressive than that. They recommend we should be trying to get systolic blood pressures under 120. And this was considered by KHA and the experts who wrote the kidney handbook, and a decision was made that on balance, we've got to try and balance the benefit of having lower blood pressure with the risks, particularly to older people, of hypotensive episodes, of blackouts, of falls. So in the Australian context, our formal recommendation is to aim for a blood pressure below 130 on 80. And first line therapy for anybody I ever meet with hypertension, I really try very hard to get them either on an ACE inhibitor or an ARB. Anybody who I'm meeting with chronic kidney disease, especially if I'm meeting them early on, if there's someone who's been referred for investigation of proteinuria, or I really want to be getting them onto an ARB for as soon as possible. and for as long as I possibly can. The benefits of the ACE inhibitors / ARBs aren't just in terms of lowering blood pressure, they also lower glomerular pressure. So I like to tell patients that you're putting less stress on the kidney. And they also are instrumental in reducing proteinuria, which is one of the targets in our treatment of chronic kidney disease. What I should also mention is that what the evidence shows us is that it is uncommon to be able to get control of hypertension, particularly in the context of CKD, with just single agent. And it is common that people need to be on 2 and 3 agents. And there is some evidence people are actually better off being on multiple agents rather than just the max dose of one agent. The exception I make to that is you want to get them on as much ACE inhibitor or ARB as they are able to tolerate. We have talked about non-pharmacological managements. Anthony mentioned salt reduction. We also talked about physical activity. This will all lower blood pressure as well. But in terms of most bang for your buck, the effect tends to be more modest. You might lower somebody's blood pressure by 5 to 10 millimeters of mercury with non-pharmacological management. And that if someone's got borderline hypertension, that may well be enough. As you've heard, I don't need much excuse to put people onto ACE inhibitors or ARBs. And I am very upfront with patients about this, that you can do everything in your power. You can completely change your lifestyle. You will probably still need medication in order to manage hypertension. One of the things that I have certainly seen is that people get started on an ACE inhibitor, there is a drop in the GFR, and they then are stopped off their ACE inhibitor, and it's not recommenced because people are concerned about the fact they've had a blood test done and it's shown their renal function has dropped. We have good guidelines about this, that as long as the drop isn't too precipitous, that we can be confident in primary care to keep the ACE inhibitor going, provided that rising in creatinine and that fall in GFR isn't less than 25%. However, in the specialist setting, we may well just monitor. We know that there's going to be a drop, and then it's more it plateaus out over time. So sometimes we are happy to continue with the ACE inhibitor, even wearing that there is a drop. I'm not going to labour this too much, but just to say that, as I said, cardiovascular disease and renal disease go hand in hand. Lots of evidence for statins in terms of not just lowering cholesterol, but plaque stabilization as well. There's other benefits to them that are not just in the lowering of the numbers. So people who are able to tolerate statins are best on a statin. If they're not able to, that's when we should be looking to the other agents. And I do try and get as many of my patients as possible onto statins. Now, newer in the picture, the SGLT2 inhibitors have been around for a couple of years now, and are now able to be prescribed on the PBS for CKD, which is very exciting. The main thing that I look at when I'm looking at whether I can prescribe someone an SGLT2 inhibitor, obviously, if they've got diabetes, it's much more straightforward. If they don't have diabetes, then looking to see whether they have an ACR of over 22, and many people with chronic kidney disease do. If you can, getting people onto these agents as well, they have an additive effect with ACE inhibitors / ARBs in terms of slowing that progression to end-stage kidney disease. They also do cause, because they're a diuretic, they have a diuretic effect, they cause excretion of glucose. You do see a little bit of a drop off in GFR, but again, what you're seeing over time, if you look at the graphs, is that you get a drop in GFR and then it plateaus after that. And I think that is all. The main thing I warn people about, and the side effects that I've seen with starting things like dapagliflozin, are about sort of worsening of UTIs and thrush, and that's, in fairness, the main reason I've had to take people back off them. If I can't get them on it because of they haven't got diabetes and they haven't got significant enough proteinuria, Also check to see whether they meet the criteria for heart failure as well, because I do find that some patients I'm not able to get on for those aspects of their chronic kidney disease, but they have concurrent heart failure and you're able to prescribe for that. Now, even newer again, finerenone is a non-steroidal mineral or corticoid antagonist. There is evidence that this is effective in slowing progression of CKD. I unfortunately have struggled to get people onto this drug, and that is predominantly because these people with diabetic kidney disease who are already on an full dose of an ACE inhibitor tend to be prone to hyperkalemia, as with the action of this drug, it does cause hyperkalemia as a side effect. So I haven't got a lot of personal experience with using this drug yet. Hoping to have an opportunity to talk about hyperkalemia management towards the end of the talk with the case study, but to let you know that it is available. And then coming last of all to the GLP-1 receptor agonists. So these are approved to be used in combination with metformin, with sulfonylureas, with insulin. It can be tricky to get the right combination of drugs in order to for people who need to be on metformin, SGLT2, insulin, and you want to add one of these as well, because one of them will end up not being covered by the PBS. However, we're waiting for PBS to catch up on that. You can ask people to pay for the metformin and have that as a non-PBS item. So the formal recommendations are not to use them in people with chronic kidney, with stage 5 CKD. What I would say is that we certainly do have some of our dialysis patients on these agents, but it's something that I would recommend doing with the help of your treating nephrologist. Almost certainly, if you're looking after somebody with a GFR of less than 15, I would hope that that there's a nephrologist helping you out somewhere in the picture. And if you did want to prescribe for one of these people who had CKD5, then doing it in consultation with a renal specialist. Very good. So one of the things that I do often get asked about by some of my general practice colleagues is about which medications we particularly need to think of reducing and stopping in people with advanced chronic kidney disease. So particularly thinking CKD 4 and 5, GFRs of less than 30 and particularly less than 15. The ones that are highlighted in red here, it isn't because these are particularly important. These are just the new drugs that have been added. The particular ones that I might draw attention to, some of the antiviral drugs, famciclovir and valacyclovir can give people quite nasty neurotoxicity if they're given at full dose. They need to be renally adjusted. Digoxin and the direct-acting anticoagulants, rivaroxaban, apixaban, and not so much apixaban, but certainly rivaroxaban can really build up, so needing to be careful with them. As your renal function drops off, your excretion of insulin also tends to drop off. So you notice this paradoxical improvement in people's glycemic control when they get advancing CKD. So you might need to pull back on some of their other agents. I think that's probably they would be the main ones. I do try and keep people's metformin going as much as I can because I do think it's a good drug for management of diabetes for a number of reasons. But you do have to be very careful in the advanced CKD space. Again, I'd be talking to a renal specialist about that. The nephrotoxics, the ones that we particularly want to avoid, the big one that I warn patients about is non-steroidal anti-inflammatories. They've usually heard it from probably you guys before they've seen me, because we're really wanting to avoid that combination of ACE inhibitor and non-steroidal when people are volume depleted because they're sick. So they've got COVID or the flu, they're feeling crummy, they're taking an NSAID, they're still taking an ACE inhibitor, they're not keeping up their fluid intake. That's when we see some really quite significant AKIs. A question that I get asked about sometimes is about use of contrast. It's very controversial. Certainly, there's been some very robust discussions between nephrologists and radiologists about this. There is evidence the newer agents, the contrast agents, are less nephrotoxic. There does still seem to be some effect, particularly I think a contrast is often a vasodilatory agent. It causes people to be flushed, and in somebody who has very borderline kidney function, that can be that vasodilatory, that dropping of the pressure in the kidneys can be enough to cause an acute kidney injury. There are calculators you can use online to try and work out how high risk it is. People with heart failure, particularly diabetics, are more at risk of having having an acute kidney injury. The best thing that you can do in terms of reducing that risk, one is holding the ACE inhibitor around the time you want to give the contrast. Two is giving less contrast if you are able to. And three is making sure that they're not volume deplete. So we used to admit people for prehydration. For people who are still high risk, we still do try and prehydrate them, but just telling people to make sure they've had enough to drink beforehand. We have been doing this a lot in my clinic in Broken Hill recently, which is giving people a sick day action plan to stick up on the fridge to remind them of medications that they should stop when they are unwell. Flu, COVID, gastro, any other reason, reminding people that they should be stopping their ACE inhibitors, that they should be not stopping, they should be holding their ACE inhibitors, they should be holding their sulfonylureas, they should be holding their metformin while they're unwell, and then they can, once they start eating and drinking normally, they can go back to taking them again. And I really would encourage you, as I say, I do try and do it with my patients with CKD, encourage you, if you have a spare moment, can be a really helpful thing to do. I think this is my last slide, which is just a summary of what we've spoken about. So as I mentioned, trying to get people's blood pressure, the main things we're trying to do, get people's blood pressure under 130 on 80, trying to get control of proteinuria, and that's predominantly with ACE inhibitors, to a degree with weight management, trying to get people onto statins, both for cholesterol management, but also just for general cardiovascular benefit, and doing our very best to keep on top of people's diabetes, with the added benefit that many of the newer diabetic agents actually have independent benefits for chronic kidney disease as well. And just to kind of reflect that I think the KHA CKD handbook has a lot more resources in it than I've presented today. And there's lots of opportunities. It doesn't just have to fall on you. There's lots of opportunities to involve other people within your practice to help reduce the risk of CKD progressing.